Good evening, friends, and welcome to the test and discussion of the fourth AIIMS Fast Track series. I hope you guys have given the test, right? And basically, this test was centered around the medicine and allied subjects, right? So, we have covered the medicine and allied subjects, which include pediatrics, dermatology, psychiatry, and anesthesia, along with the core aspects of general medicine, right? So this test was of 25 questions, and as with the previous test, I hope you could find the integration between the different subjects, the association of the practical concepts, the images, and the theoretical aspects with one another. So, without wasting time, let us discuss the different questions which were there in the test today and how to approach them. Right? So, this was the first question. A 35-year-old female with the history of malabsorption syndrome presents with intensely pruritic erythematous grouped vesicles on the elbow and the knees. What is the likely immunofluorescence pattern observed in this case? So, friends, if you carefully observe this first question, what you will realize is we have tried to integrate multiple subjects with one another, right? Mainly three subjects we have tried to integrate here, right? We have tried to integrate dermatology with GI system in medicine with pathology, as you can see from the options, right? So we have tried to integrate these three subjects here. Basically, what the question is asking is there is a middle-aged female with a history of malabsorption syndrome. So she is having a malabsorption syndrome of the GI where she is not able to absorb the nutrients, and she is presenting to the dermat OPD with intensely pruritic, that is itchy, erythematous grouped vesicles. So basically, she is having a vesiculobullous disease, right? She is having a vesiculobullous condition, and these vesicles are grouped, pruritic, and erythematous, and the site is elbow and knees. So basically, the extensor aspects are involved. What is the likely immunofluorescence pattern which is observed? So the four options are the four different immunofluorescence patterns of four different diseases, right? And first of all, you have to identify which disease the female is suffering from, and then you also have to see that what is the immunofluorescence pattern, which is a pathological finding, the investigation, histopathological advanced investigation, right? So basically, the entire presentation is classical of a condition known as dermatitis herpetiformis. Dermatitis herpetiformis is the diagnosis in this case, and this condition is classically associated with celiac disease. Celiac disease or the celiac sprue, which is a malabsorption syndrome, right? It typically affects middle-aged females, and here basically there is gluten sensitivity, right? In celiac sprue there is gluten sensitivity, and in dermatitis herpetiformis, as the name suggests, herpetiform means grouped vesicles. So herpes, the name herpes and the term herpetiform both are related to the grouped vesicles, right? So because this is a dermatitis having grouped vesicles, it is known as dermatitis herpetiformis. They are intensely pruritic and erythematous and mainly involves the extensor aspects of the limbs. So in dermatology in conditions, these are very important things which you have to pick up from the question. What is the site of involvement? What is the epidemiological findings? Which gender is involved? What age is involved? What are the clinical symptoms associated with the lesions, right? Whether there are erythematous, pruritic, nodular, vesicular, what is the morphology of lesion? All these things you should think of and you should associate when you are evaluating a case of dermat, right? And now the four different patterns. So in dermatitis herpetiformis, the papillary tip microabscesses are seen. The immunofluorescence finding of dermatitis herpetiformis is papillary tip microabscesses, right? And these papillary tip microabscesses are mainly composed of IgA antibodies, right? So the autoimmune IgA antibodies, they are making the papillary tip microabscesses, and you can see evidently in this image that this is the papilla and this is the tip of the papilla which is showing the IgA antibodies which are producing the green immunofluorescence, right? So this is the immunofluorescence finding of dermatitis herpetiformis. So the answer is option C. Now, before going to the description of this condition, let us evaluate what these three other options are, right? So basically, this is a linear pattern. This is also a linear pattern, right? But this is along the interface of dermis and epidermis, which is classically seen in bullous pemphigoid, right? So this is the classical immunological image, immunofluorescence image of bullous pemphigoid, right? Then this is a fishnet appearance. This is a fishnet appearance which is classically seen in pemphigus vulgaris and the other type of pemphigus, right? So pemphigus vulgaris shows this fishnet immunofluorescence pattern. This is again a linear deposit of IgA antibodies, which is seen in a condition known as linear IgA disease, right? So this is, the name itself is suggestive. Linear IgA disease shows this linear immunofluorescence pattern. So this is bullous pemphigoid image. This is pemphigus vulgaris. This is dermatitis herpetiformis, right? And this is linear IgA disease. So the characteristic morphology of the lesion with the history of malabsorption, which is probably a celiac disease in young females, points to the diagnosis of dermatitis herpetiformis. The antibodies are very, very important and they are frequently asked. So anti-tissue transglutaminase 3 antibodies and anti-endomysial antibodies, they are diagnostic, right? This is the most sensitive investigation, most sensitive antibody, and this is the most specific antibody. Please remember these two facts, right? Drug of choice is Dapsone for dermatitis herpetiformis, whereas the treatment of choice is gluten-free diet. So basically, this condition is associated with the gluten sensitivity. So the definitive treatment is gluten-free diet. But if the drug of choice is asked, then Dapsone is the answer. And immunofluorescence shows granular IgA deposits at the tip of papillary dermis, as we have seen in the image, right? So this was the first condition where we have integrated dermat with GI medicine with pathology. Coming to the second question, which of the following psychiatric disorders are included in the trauma and stress related disorders as per new ICD-11 classification? So in psychiatry, the new ICD-11 classification and the conditions, especially the new conditions, the new additions which are added in different group, that is very, very important, right? And one of such groups we have taken for making this question, it is the multiple completion type of question. We have 4 options, out of which we have to pick up the correct ones. So complex post-traumatic stress disorder, prolonged grief, reactive attachment disorder, and disinhibited social engagement disorder. So friends, this might be new information for you, but all these four conditions are included, are the new additions in trauma and stress related disorders in the new ICD-11 classification, right? So this might be a new information for you, but I wanted to highlight this fact that ICD-11 is a latest thing in psychiatry and it is a must know topic. So all these 4 conditions are the new additions in the ICD-11 classification. So in the explanation, I have given the different categories of psychiatric illnesses and the respective new additions in the ICD-11, right? So these are ICD-11 new inclusions. In anxiety disorders, we have 2 new additions. One is separation anxiety disorder and second is selective mutism. In OCD and related disorders, we have hypochondriasis and olfactory reference syndrome. In trauma and stress related disorders, the 4 conditions which we have discussed. In impulse control disorder, compulsive sexual behavior disorder is included. This is a new addition. Then there are 2 new categories which were not there in ICD-10. One is disorders of bodily stress or bodily experience, and it includes bodily distress disorder and body integrity dysphoria. Then second new category is disorders due to addictive behavior, in which there is gambling disorder and gaming disorder, right? So all of these new conditions, all of these conditions are the new additions in these respective categories, right? You don't need to go in depths of all these conditions. What are they? What are the symptoms? It would rarely be asked, but at least what you should know as of now for the upcoming entrance exam is what are the new additions in the respective categories, in these different categories, right? So this is the list for last minute revision, right? This is the list for last minute revision which you should see before going to the exam. Coming to the third question. The third question is regarding critical care, right? The CPR is the topic, and as we have already discussed multiple times, CPR is a very, very important topic from entrance exams, especially the Central Institute entrance exams, right? So we have four statements here, and we have to see which one is false, right? All are true except. So we have to pick up the false statement. Depth of compression should be at least 5 centimeters. Complete chest recoil is allowed between the compressions. The end tidal CO2 pressure, if it is less than 20 mmHg, then the quality of CPR needs to be improved. And the chest compression to ventilation ratio should be 30:2. Now, these all specifications which are mentioned in the options, they are regarding the quality of CPR. So whenever we are performing the CPR, it is always the time, it is always a situation where time is money, and you have to take the actions in a very rapid manner to save the patient. But at the same time, what we also have to ensure is that the quality of CPR that we are giving is effective. Otherwise, what happens is we go on giving CPR, but it does not give the required advantage, and it does not provide the benefit in the survival of the patient, right? So what are the points to be considered for ensuring good quality of CPR? First is the depth of compression. Yes, it should be at least 5 centimeters. So it should be hard and fast compression, right? It should be hard and fast compression. 5 centimeters should be the depth, right? The sternum should be pushed 5 centimeters. Only then the thrust will reach up to the heart, right? Otherwise it will not reach up to the heart. Then comes the complete chest recoil, right? So this is again a very, very important thing. Between two compressions, you have to ensure that the elastic recoil, the chest recoil, occurs completely. It is not that it is not that you go on pushing the chest, right, without complete recoil. Otherwise there won't be effective pumping, right? So relaxation and compression, both the phases are equally important. Then comes the end tidal CO2 monitoring. So end tidal CO2 monitoring should be less. If it is less than 10 mmHg, then there is the need to improve the CPR, right? So this becomes our false statement, and the correct answer here, that the end tidal CO2 should be less than 10 mm to warrant an improvement in the quality of CPR, right? So less than 20 is not the correct answer. 20 is the cutoff for something else which we will discuss while we are discussing the other points. The chest compression ventilation ratio 30:2 is absolutely a correct statement, right? So these are some facts regarding the quality of CPR which are mentioned in the BLS guidelines. So it should be hard and fast push. The rate should be 100 to 120 per minute, and the depth should be 5 centimeters or 2 inches. No movement should be done at the elbow joint. Only the shoulder should be moved. Elbow has to be fixed, right? This is again one thing which is usually assessed in the practical aspects, right? That when we are pushing in a hurry, we are undergoing the movement of the shoulder elbow joint. That should not happen. Otherwise, it will reduce the effectiveness of the CPR. Adequate chest recoil should be allowed. There should be minimum interruptions in the compressions. Avoid excessive ventilation. The compressor should be rotated every 2 minutes or sooner if fatigued. If no advanced airway is obtained, then 30:2 compression ventilation ratio should be maintained. Capnography is the investigation of choice for monitoring the quality of CPR, and the cutoff is 10 mmHg. So if the end tidal CO2 is less than 10, then quality of CPR should be improved. Then another monitor which can be used is the intra-arterial pressure monitoring. So in the intra-arterial pressure, the diastolic pressure should be less than 20. Then if it is less than 20, then we have to improve the CPR quality. So diastolic pressure cutoff is 20 for improving the CPR quality. That is intra-arterial pressure monitoring, but that is not usually done. Though it is included in the criteria for CPR quality, we usually don't perform. Capnography is the investigation of choice for assessing the quality of CPR, and the cutoff is less than 10 mmHg to improve the CPR. So the steps of CPR, the specifications, and the ways of monitoring the quality of CPR is very, very important. It is a very trending and hot favorite topic for examiners in Central Institute. So don't try to skip this topic, right? It should be covered. Next question. So now next question is from neonatology, right? Neonatology is the single most important subsection of pediatrics, and if you have to read one topic in pediatrics, you should read neonatology, right? So here we have a full term newborn baby delivered 4 hours ago by cesarean section, who presented to the neonatologist with respiratory distress, right? So respiratory distress is one of the most common pathological findings which is seen in a newborn, which requires immediate intervention, right? There was no fever, no chest indrawing, or any abnormal sounds. CXR image is shown and diagnosis is asked, right? So basically, now the 4 options which are given here, to rule out the other options and to reach to the correct answer, you need the help of both the image as well as the history. So this is a very classical case presentation where all the things, each and every word which is given in the question, that is important, right? So sometimes, as we have seen previously also, in some cases the image itself can give you the answer, in some cases the history itself can give you the answer, but here both the things are required. So let us evaluate the case properly. So basically this was a full term newborn, right? And as soon as I read this word full term, I should remove this option from my consideration. Hyaline membrane disease is a condition which produces respiratory distress only when the child is preterm delivered, right? Because it is a surfactant deficiency situation, it will affect only the prematurely delivered babies, right? Never the full term babies. Otherwise this image can be produced, this type of chest x-ray finding can be seen in hyaline membrane disease if this is a premature birth, right? If this is a premature birth, then this chest x-ray can be suggestive of hyaline membrane disease, but because this is a full term delivered child, we are ruling out hyaline membrane disease, right? Now the patient was delivered 4 hours ago, right? So the condition which we are discussing, it has nearly an immediate onset of the presentation, right? So as soon as the child was delivered, and see, the child has been delivered by cesarean section, so this is also a very important point to be considered. So cesarean section is also one of the very important risk factors which is playing a role in the condition that the question is depicting, right? So 4 hours ago, the child was delivered by cesarean section. Now, coming to the negative findings, there is no fever. So that again rules out lobar pneumonia. That again rules out lobar pneumonia, because in pneumonia, the fever, chest indrawing, abnormal respiratory sounds, these are very classical findings, right? These are very classical findings in lobar pneumonia. So none of this is present, so we can easily rule out lobar pneumonia. Now comes the 2 options: congenital diaphragmatic hernia and transient tachypnea of newborn, right? So what is the answer? Now let us come to the chest x-ray. So friends, if you evaluate this option, congenital diaphragmatic hernia, if you don't know anything about this condition, then also from the term itself you can interpret one fact, that basically this is herniation through the diaphragm, right? Herniation through the diaphragm. Now if you evaluate, the diaphragm separates the abdomen from the thorax, right? And obviously the abdomen has positive pressure while the thorax has a negative pressure, right? So if there is any herniation from the diaphragm, obviously it will be from abdomen to thorax, right? Obviously the contents will herniate from high pressure region to low pressure region. So it will, the contents will herniate from abdomen to thorax. Now in abdomen, what are the contents? Bowel loops, right? So if bowel loops are herniating into the thorax, you can obviously see the air fluid levels and the gas filled bowel loops in the thorax, right? But here we are not seeing, any such finding. In the chest x-ray, we are not seeing any herniation of the bowel loops. So obviously this is not congenital diaphragmatic hernia. What remains is the transient tachypnea of newborn. So transient tachypnea of newborn is the correct answer here, right? It is showing the sun ray pattern. It is showing the sun ray pattern of the radio opacities, right? Sun ray pattern of radio opacities and the fluffy nature, the fluffy nature of the radio opacities, which is a classical finding of transient tachypnea of newborn, and it is classically seen in the cesarean section delivered babies, full term babies who are delivered by LSCS, because their lungs during the passage, during normal vaginal delivery, what happens is the child undergoes a bit of distress, and so the lung becomes active and the child is able to breathe, right? The child is able to breathe once he gets delivered because the lungs have started producing the respiratory effort during the delivery. In cesarean section, what happens is the abdomen is cut open, the child comes out suddenly, right? So the child is not used to the respiratory effort, the child has not underwent the respiratory effort, right? And as a result, when the child gets delivered, there is a transient tachypnea. There is a transient tachypnea. It is a self-resolving condition. It is not a very severe condition, right? It resolves by itself and it is transient. Usually seen in full-term babies who are delivered by cesarean section. The chest X-ray appearance is the sun ray appearance, the sun ray pattern emerging from the hilum and radiating to the periphery, right? So this frontal radiograph is showing streaky perihilar linear densities, indistinctness of the blood vessels and fluid in the minor fissures. These all are signs of increased fluid in the lungs. So basically, once the respiratory effort starts, then the fluid gets cleared off from the lungs. But in this child, the respiratory effort only has not started because he was abruptly delivered and the environment to which it belonged for 9 months, it has abruptly changed, right? So the lungs are not cleared of the pulmonary fluid, and as a result, the transient tachypnea develops. It is usually seen in full-term baby who are delivered by cesarean section or a fast labor, right? Precipitous labor. Mild respiratory distress is there, which improves within several hours, right? Imaging findings, we see hyperinflation of the lung fields, fluid in the fissures, laminar effusions, and fuzzy vessels, because you cannot differentiate the fluid in the fissures from the bronchovascular markings. Treatment is oxygen support on a temporary basis, maintenance of body temperature, and mostly the improvement occurs within the 24 hours. That is why it is known as a transient tachypnea of newborn.